All right, thank you. Good morning. It's a pleasure to be here, pleasure to be a sponsor of today's event and to have the opportunity to introduce our speakers today. My name's Brant Gall with All Lines Technology. For those of you who are unfamiliar with All Lines Technology, as Audrey mentioned earlier today, we are a local based out of Cranberry, PA, woman-owned strategic IT solutions provider. I say strategic because we truly want to partner with our customers, like Dick's Sporting Goods, Alcoa, UPMC, in understanding their business goals and the IT initiatives that help execute against those those business goals, something that was talked about in a few earlier discussions. That lends very well to the big data conversation that we are having today. Being a true end-to-end solutions provider, we are able to provide our customers a wide range of solutions and services. For example, MSP hosted cloud services like infrastructure as a service, backup as a service, expertise around BI, something that was discussed earlier today, and Microsoft Cloud Solutions, IT consulting, again ties in nicely with everything that's being discussed, IT staffing, and enterprise infrastructure through strong partnerships like we have with our friends from HPE. But enough about All Lines Technology. It is my pleasure to introduce Dr. Pamela Peele. Dr. Peele's credentials speak for themselves. Most notably, to me, when I was reading over her bio, was that she was chosen by IBM as an IBM Big Hero and was voted the 2014 IT News Men and Women of the Year as a top innovator in healthcare analytics. It's pretty impressive stuff. Please join me in welcoming Dr. Pamela Peele.
Thank you, Grant. First of all, thank you to the organizers for inviting me to come here today. I'm going to show you some of the stuff that we're doing across UPMC, particularly on the insurance services side, and thank you for coming this morning. This will be a pretty fast whirlwind, so buckle your seatbelts and we'll get started with what we're going to do. First, a little background. So I am the Chief Analytics Officer for the Insurance Services Division. The Insurance Services Division, as many of you know, UPMC is like a big company. And about over half of its revenue comes from the Insurance Services Division. And we cover over 3 million covered lives on that piece, and we sell a ton of different products. We're in 43 different states, so we're not just Western Pennsylvania, depending on the products that we sell. And I'm also the Chief Analytics Officer for UPMC Enterprises. Enterprises is our venture capital arm. So that my desk there is actually a cube, and it's out in Bakery Square, and I show up in blue jeans and tennis shoes on the days that I spend at Enterprises, and I show up in something that looks a little more corporate on the days I come downtown. So now we're a big company. Let's talk about this. Big data is not for the weak of wallet. That is the first thing. You cannot dabble in big data. You have to have the infrastructure and the IT and the architectural stack to do this. And if you can't invest in that, you don't have any business being in this. So this is the $833 million. It's a lot of money. $833 million is how much money Pittsburgh spent on 3 different sports stadiums. And I have never been in a city in my life that consumes sports with the veracity that Pittsburgh does. In fact, the first time early on when I was here, it was Steelers Friday. I had to go home and change my clothes because I did not show up appropriately dressed in black and gold. So I just didn't understand and appreciate the passion there is in this city. $833 million. Trivia question. What is the only city in the United States where all of their major sports teams have the same colors? Right here. That's exactly right, black and gold. UPMC has invested over $1.6 billion. $1.6 billion in our IT infrastructure to support what we're doing. That's not our analytics, that's our IT infrastructure. So we've invested far more than what we've invested in sports. I think in Pittsburgh, that says a lot. All right, here's the point of big data. Anybody know where this is from? Anybody been to Cusco in Peru? No, all right, I'll give you the background. So when the Spaniards came and conquered Peru and invaded, took over the Incas, took them prisoners, they had the Incas, who were very skilled craftsmen and artisans, had beautiful temples. The Spaniards had the Incas take down their temples and erect on the same site a Catholic church. And inside the Catholic church, they had the Incas artisans decorate the interior of the church. Church is beautiful if you ever get a chance to see it. So this is the Incas' representation of the Last Supper. Friends, that is not a turkey on that platter. That's a guinea pig. That's exactly right. It is a prized food in Peru. What does this have to do with big data? The point of big data is to consume something different. So if we make all of this investment, and we hire all these people, we do all this fancy stuff, and the organization doesn't change what it does, or doesn't change the decisions that it makes, we just wasted our money, and I just wasted my time, quite frankly. So the way to measure, in my mind, the value of big data in an organization is how much influence does the information have on the organization's decision-making. So the whole point here is to consume something different. So let's take just a second and make a differentiation between what we mean when we say IT and we say analytics. This is a point of confusion, I think, for many companies, particularly at the beginning of their journey. So here's what happens. We're in the boardroom. We're going, I'm hungry. I'm hungry here, folks. We got nothing to eat. Why don't we have anything to eat? You're the one who's supposed to be in charge of IT. Why isn't there anything to eat here? Okay, boss, we're going to invest in it. Well, no wonder there's nothing to eat. Look at the kitchen. Look at the state of our kitchen. We need to invest and upgrade our IT stack. Whew. Thank God. We got the whole thing upgraded. Meanwhile, back at the table, there's nothing to eat. So what happens next? We invested all this money in this IT stack. Where is my information? I told you we should have bought the better pots and pans. It's your fault we didn't buy the good pots and pans. The difference between IT and analytics is this is IT. IT is the kitchen. If you don't have a kitchen to cook in, you don't need a cook. But if you've got a kitchen to cook in, you need a cook. And that's what analytics is the cook. Now, how does this fit together into healthcare and big data? One of the pieces that big data allows us to do, it brings us clairvoyance. Don't you love that word? Try saying that a couple of times. Clairvoyance, isn't that a wonderful word? That is, we don't know what we don't know. We don't have to know what we don't know when we have big data, because we can approach hypothesis-less testing here. So we can do pure knowledge discovery as opposed to testing hypothesis. That is the beauty of big data. So this is how we are organized. I'm just going to put this up very quickly because I want to talk a little bit about the organization of what we do to approach our data, and then I'll start showing you some of the projects that we've done on the back side of this data. So this is on the insurance services side. This is where IT lives. All those data live in IT, they're governed by IT, they're brought in by IT, they're moved around by IT. Whoever touches them is monitored by IT. This is IT, this is analytics. So here's the interface right here between IT and analytics within this organization. We never mess with the granularity of our base data. It is always preserved, but we lift it up and transform it into what I call the groomed layer. It's actually many layers. And then we consume off of that groomed layer, otherwise known as SPOT, a single point of truth. Somebody mentioned it this morning in their talk, that the worst thing that can happen is you go to a meeting, there are 3 analysts there. How many something do we have? You get 5 different answers from the 3 analysts. The rest of the meeting is a discussion over which answer we like the best. The 3 analysts go back to their cubes. They spend the next 2 weeks trying to prove that their answer was the correct answer, and nobody was actually correct. So this is really important that you get this groomed layer up inside your organization so that you can come down and consume on this. One of the things about big data, most of the data that we're going to use, any of us, in a big data application, those data were not created for what we're using them for. Claims data are not dirty. There'd be nothing dirty about claims data. What are they? Bills. What happens when they get submitted? Doctors get paid. Is there something amiss in that? No, there's nothing amiss in that. Works exactly as it's supposed to work. Only now we're trying to lift up these data and do population health management on them. And that's a whole different ballgame. It's a whole different nuance. So one of the pieces about handling big data is we are rarely working on information that was primarily created for the problem we're trying to solve, which means you need a lot of institutional knowledge, not just math and science, to fling this stuff around. So we lift it up into our groomed layer, and then we build rules engines, we learn rules engines, we use a lot of artificial intelligence, we manage our population through something called Health Planet, which is our own homegrown population health platform. And then it is a portal. You can come in locally or externally and manage and create reports out of it. That's great. Now you're almost ready, because this is the other piece. If you can't get your data groomed and ready to be consumed, you don't need a data scientist. You don't. Why would you pay a PhD data scientist to come in and wrestle with your alligators every day? You have got to get your data together. And let me tell you, it takes a long time. It's not sexy. There's no great glamour to it. It's actually really hard. And you can't do anything cool until you get this done. So it really requires biting the bullet and settling down and getting your data ready to be consumed in big data. Here's the other piece. So we run a hub and spoke model in our analytics structure. So we have a centralized knowledge discovery factory, is what I like to call it. Has about 40 people in it now. And then we have analysts or reporting analysts embedded in different pieces of the organization. We do pure knowledge discovery out of the centralized shop. When we're going to put something in production, we move it out of the centralized shop and move on to the next problem. So we are not producing, in general, any kind of routine reporting out of that centralized shop. That is a knowledge discovery shop that contains, everybody is a PhD or a master prepared individual. We have physicists, we have epidemiologists, we have statisticians, we have economists. We have a pretty broad variety of people inside that shop. The second most important person in that shop, hands down, is my foreman. Your analytics shop is a factory. We don't make widgets, we make knowledge. It's the same concept. Run it just like a factory. The most important thing in your factory is your foreman. Second most important thing. Because you've got to move work through your factory, and then keeping that work moving so it doesn't fall on the ground and it gets out the door and it gets consumed. That's incredibly important. And this is actually, I actually refer to her as the foreman that runs this. That's the second most important person in this centralized shop. Who's the most important person? No, not yet. Where did you get your news this morning? Remember what I said? The whole point of this is to consume something different. If what you produce is not consumed by the organization, you just wasted your time and they wasted their money. Where did you get your news from this morning? Twitter. Pretty sure. Scary, folks, isn't it? Oh, my God. And my Social Security is dependent on you. You are scaring me. So, well, Most people who run organizations get their news filtered through a professional journalist. They're reading Forbes, The Economist, The New York Times, The Washington Post, the Wall Street Journal. They're reading the Bloomberg. They're reading something with news that they are consuming. It has been filtered by a professional journalist. Who's the most important person in this shop? Our journalist. And we have two of them. Took me a long time to figure this out. It doesn't matter what you produce. If it's not consumed by the organization, it doesn't have any value. So if you want your big data approach to have value, it has to be consumed by the organization. And you can't expect CEOs and managers to come and consume your big data applications in the raw math form. If you want your biostatisticians to write the reports for your CEO, oh dear, dear. Unless your CEO is a biostat, you have a little bit of a problem here. You have got to get it transformed so that it can be consumed by the organization. It's incredibly important. Now we're going to, start through this piece. I just want to touch briefly. Has anybody in here been to Tuffy's workshop? Oh, yeah. Isn't that great? That's just fabulous. So he's a big Edward Tuffy. He does the visualization of quantitative data, which is also a book, very much worth reading. The workshops are very much worth going to. He does them across the country, and maybe he does a dozen or so a year, I think, something like that. They're not terribly expensive, and they're definitely worth a day of your time to go and see that. So here's the piece. Remember I said, if you can't consume it, it doesn't have any value. This is a super graphic. We should all strive to put the output of what we do into a super graphic. Why? Because I don't need words or math to work on it. This is a very famous super graphic, which is why I like to use it. This is Napoleon's invasion of Moscow. So the big wide river here is the army, Napoleon's army, as it started out for Moscow. So you can see it's really quite wide. It was several 100,000. Everything that's in light-colored river is going towards Moscow, and everything that's in black is going home. So what you see here is, if I can do this, it looked pretty good at the beginning. A little group broke off right here, and then they retreated and came back. A flank came out back here. They never went anywhere. They retreated and came back. It gets a little smaller and smaller and smaller. We get to Moscow, lose almost no army in Moscow in the conflict. We start back. Down here is temperature. You gotta love this graphic. It's got like everything you want. Those are rivers. Look what happens. Not going good. Ooh, temperature going down, not going good. Oh my. This is a river crossing. Highly unsuccessful, I would say. So on that one super graphic, you can see the temperature. You can see that the winter actually defeated Napoleon, not Russia, on one super graphic. So this is what we strive to try to communicate with. Now I'm going to go through a series of some examples of what we do with our data and how we think about it. And there's just going to be a whole series of examples here. We have a lot of data. So we create every month, for every member of the health plan, we predict the risks that you're going to be readmitted to the hospital should you be admitted today. It's a conditional readmission model. It's a thing of beauty. It is not at all what we started out. It was not the problem we started out to solve. This is just collateral benefit on the way to solving some other problem. So every month we are predicting the probability that you will be readmitted to the hospital 30 days in EDRG if you were admitted today. So we don't need to see your index admission. Diagnosis doesn't matter. The secret sauce in this model shocked me never in a million years would I have thought of that. When I see it, it makes sense to me, but I would never in a million years have thought of doing that. This is the beauty of using AI. We don't know what we don't know. So what did we do with this model? It's really a lovely model. Well, of course, We went after the high readmission people. And we actually take this information and we push it into our hospitals. So when Susie Sunshine, our member, comes into one of our hospitals and is about to be admitted, the hospital is getting the authorization for the admission. In the upper right-hand corner, in big real estate, is her readmission risk, so that her discharge planning can start on admission, depending on her readmission risk. And where did we go initially? Yes, we went after these really high readmission risk people. And what happened? That's right, nothing. These people are really sick. So it took us a little while to learn that we had to move down the probability scale, and there's actually a little sweet spot. It's not that these aren't important, it's that readmissions have become a rare event down here, and you have to touch everybody. So now you are dispersing your resources too thin to have a very good impact. Up here, lots of readmissions. Trust me, walk away from the bus. They need to go see their doctor. But in the middle part right here, you can get some traction on preventing readmissions. And what is that traction? Home health. Home health post-discharge. So a piece of, this was not what we started out to solve. It was just a collateral benefit of solving a different problem. So then after we did this, it's a little more complicated than it looks, but it's got a nice clean look to it. So then we said, wow, does follow-up in the clinic post-discharge matter to your readmission risk? Yes, that would be a yes. And when does it matter? 5 days. 5 days, right here. You got to do it in 5 days or you lose the benefit of doing it. We were using metrics on our physicians that had a 14-day follow-up. Whoop, wrong. Got to be 5 days. What did we do with this? We changed the metric for our physicians. We have thousands of employed physicians to be 5 days. Follow up within 5 days post-discharge. And what did the physicians want to know? Were those 5 business days? No, they're not 5 business days. It is 5 days, 5 continuous days. They did want to know why, and they were very convinced when we showed them the information that we did behind this. So that was pretty successful. Well, this isn't being. There we go. So there's a piece here I want to talk just a moment on my soapbox about, which is it matters what the metric is that you're measuring. CMS, Medicare, the government, has a measure of readmission, very focused on readmission, particularly for certain discharge diagnoses. And in fact, they will financially punish hospitals over all of their Medicare admissions if they don't meet certain readmission rates on, I think there's 5 different discharge diagnoses. So what happened when that happened? Yeah, they moved the cheese around, hospitals responded. Doctors are really smart. And so what happened to our readmission rate? This is our readmission rate. That looks like it went up. It went up. We really focused on it. We focused hard on it. So did a lot of other hospitals. Here's what the problem is. Here's the way you got to rub 2 neurons together before you jump into the pool, folks. What is the readmission rate? It's a rate. What is it comprised of? That is the number of total discharges. How many people get discharged? What's the readmission rate? That's the denominator. What's in the numerator? That's right, readmissions. So readmissions actually turned the corner and went down, but total admissions went down disproportionately more than the readmissions. Think about that for a moment. Who can you keep out of the hospital? It's probably not the lung transplants. So the admit on the margin the one that you can keep out of the hospital, actually has a lower readmission risk associated to it than the admits that you cannot keep out of the hospital. So what happens when you concentrate on this is you concentrate sicker and sicker patients into your denominator, and your readmission rate goes up. So rather than being a metric of poor quality for a hospital, a rising readmission rate could actually be a metric of good quality. CMS hasn't gotten this message yet, but we're working on it. So then we want to look at what happens is there variation in care. This is really an interesting graph. It's a little complicated, but I'll walk you through it. So this is DRG 470. These are major joint replacements without complications, without complications. We are masters at coding. We could have coded these with complications. We would have coded them with complications. Trust me, these are discharges without complications. Now, each one of these is a hospital, so read from left to right. We call these the eyeball charts, affectionately. So from left to right, this is the number of images that were gotten while the patient was in the hospital. This is the number of consults, cardiology, rheumatology, whatever, while the patient is in the hospital. That's the number of tests that they got while they were in the hospital. And that's the number of times the attending saw the patient while they were in the hospital. Imaging, consults, test, attending. The middle of the eyeball is the average. The lashes are the confidence intervals. The size of the eyeball is the relative readmission rate relative to the other hospitals. Got it? Image, consult, testing, attending, the average, the readmission, the confidence intervals. So I'm going to show you a couple of hospitals. Woo! The attendings could spend a lot of time going around attending at that hospital. So you can see there's variation by hospitals, and hospitals are more than one surgeon. Oh, isn't that interesting? So we've been having like 17 zillion meetings around protocol development for joint replacements. We'd be done. We would never have known this if all we had looked at was a bunch of electronic medical records or even a bunch of paper files. You have to be able to throw your data together in order to see this. So this particular hospital right here runs a very tight ship. Their readmissions are almost zero. And they don't have, what did the other hospitals say? But my patients are sicker. No, they're not. No, they're not actually. They're not any sicker than this hospital's patients. This is fun. So let's switch gears here. So we have lots of data, right? Oh, I love this. This is so much fun. So stay with me now. The pink dots are facilities. So they're hospitals, they're dialysis units, they're LTACs, they're rehabs, they're skilled facility, they're facility charges. The blue dots are specialists. We have a lot of specialists, a lot. And the dark dots are primary care. And what is this? This is a model of attraction and repulsion. This is actually free open source software. Yes, I use the F word, free open source software. So what happens is if a patient moves around the same facility and doctor, the facilities and doctors come together. They make a nexus. If they don't share, they push apart. So it's not a geographic model, but it definitely has a geographic tone to it because patients don't travel that far. Oh, and it definitely has a river in it, trust me, because we don't cross that either. So what happens here is this big part up here, that's really Oakland. That's our main hospital center in Oakland. And look at the bottom piece. That's, lots of patients, they move around, whatever. Look down here. Pretty big group of patients and providers and facilities, really tight. That tightness means that they keep it inside. They really stay inside with each other. Highly repelled. Really seriously, that they don't share, highly repelled from everybody else. It's not some little one-off. There's a lot of providers down here. And these ghost trails Are patients moving? What you see in this ghost trail is a figure 8. When you see a figure 8, there's something there. Otherwise, they would move smoothly between the two nexuses. What's in the middle of this figure 8 right here? This one. City of Pittsburgh EMS. So when patients move between whatever is going on down here and the main hospitals in Oakland, they overwhelmingly do it in medical transport. Again, you would never know this if you couldn't put your data together and throw it at the wall. What is this? Pediatrics. Pediatric physicians, subspecialists, our pediatric hospitals, pediatrics. This is our pediatric group down here. This group up here is interesting. Small, number of facilities, tight little nexus. They keep it to themselves. Has the same figure 8, very strong figure 8. When patients move from that into the rest of the ecosystem, overwhelmingly they do it in medical transport. What's up here? Heritage Valley. That's Heritage Valley Health System at the top. They own their own home care, their own rehab, their own skilled facilities, their own LTAC. So they are a very self-contained, enclosed facility. You would never, ever be able to see this if you couldn't visualize your data in this fashion. Now take away the facilities, and let's just go look at the physicians. There are a little over 30 natural clusters of physicians in Western Pennsylvania. What do I mean by that? I mean they share the same patients. That's what makes the nexus, is you're sharing with somebody else the same patients. We've color-coded this to try to make it a little easier. So let's start up here. This little blue group right here, first of all, those 3 groups of providers, so each dot is a provider. Those 3 groups of providers really ignore pretty much everybody else and do their own thing. This blue group overwhelmingly refers their patients to that yellow group. That yellow group refers down to that red group, and that red group refers back up to the yellow group. What does knowing this do for you? If you are changing your network or your contracting, and you take out, let's say the red group, you just made a dysfunctional network because your yellow group lost their referral mechanism. You would never know that if all you had was a stack of paper records or even electronic medical records. You have to be able to see this in a big data fashion in order to see it. It's a little different view. I'll walk you through it. Each patient, each member, is mapped to a physician that is their primary care physician. Those physicians then have a bunch of patients attached to them, right? Let's just call it the physician panel. That sounds like a good way to do it. Now, we take the panel and we say, which hospital gets the lion's share of the facility charges from that panel? So you, doctor, have a panel, and 80% of the facility charges that that panel of patients uses goes to hospital A. You are attributed to hospital A. So we're attributing you on the preponderance of the facility charges of your panel, and we make a stickiness variable. 99% of your panel's facility charges go to hospital A. Ooh, you'd be very sticky to hospital A. Versus 52% go to hospital A, you're not as sticky. So we know something about the stickiness. So these are physicians. What you don't see are the patients behind the physicians, okay? These are physicians. Now, how do these physicians move around? With more agility than I do. All right, so 3 hospitals. The local wisdom was that patients don't move between these hospitals. They're relatively rural hospitals. There is a river here and a pretty good-sized mountain thingy-dingy going on there between these hospitals. As you can see, rivers are bigger deterrents, but we're in Pittsburgh. But it's not true that patients don't move. That's not true at all. At this hospital, these providers are pretty tight. They share mostly. The patients are within and around that hospital. When they refer patients, it's hard to see these little limey things, they overwhelmingly send them down to Hospital B when there's sharing going on. Hospital C looks a lot like Hospital A. These are all providers, and they share. When they're sending their patients, they're sending them either to Hospital B or up to Hospital A. Hospital B is an interesting hospital, isn't it? There are two distinct cliques of physicians at this hospital. There's a clear group of physicians right here and a clear group of physicians right here. These physicians refer both here and here. These physicians refer down to Hospital C. And the only thing holding those two cliques, they're all at the same hospital. The only thing holding those two groups of physicians together are those three dots in the middle here. Right here. Dots are physicians. So those three physicians are common across those two groups. That's the only thing that keeps them from completely drifting apart. Who are they? They are the only three radiologists in the county. So these are actually independently separated doctors. This group acts as an independent group, and that acts as an independent group. You would never, ever, ever know this if you weren't able to visualize your data. And we didn't do this to discover how many independent groups of physicians we had. We didn't know what we didn't know. We just came down onto this data to see what it looked like. Oh, I love this. It's one of my favorites. So this is not natural language processing. We do some of that too. This is pure text mining. So we took 444,000 clinical notes, electronic medical records, 444,000 of them, and we threw them at the wall. And we said, are there words or words in the clinical notes? Forget about context. This is not natural language processing, so never mind the context. Just words or words in the clinical notes that are signals of the future use of the emergency room. That's all we're looking for here. So we threw the words at the wall, and what we found was they cluster. First of all, doctors have a very limited vocabulary. They use the same words over and over and over again, which is actually good for us. They cluster in a very specific way so that when you look at them, you can see that some of these, like these are clinic kind of notes, and these are inpatient. These are administrative types of notes. So there's a distinct clustering. But the question was, are there words or words that are signals of future bad juju? Are they going to show up in the emergency room? And the answer is, oh my God, yes, yes. Mother. When the clinician writes mother in the clinical note, all is well. Very low future use of the emergency room. All is well. WW. When the clinician writes WW in the clinical note, run from the room with your hair on fire because bad juju is coming down the pike. What is WW? I don't know. I'm an economist, for God's sakes. Give me a break. What is WW? So we had to go and ask the clinicians. But we couldn't tell the clinicians why we were asking them because that might change their behavior and then we'd have to retrain the model. I'm like way too lazy for that. So we managed to get out of them wheeled walker. Wheeled walker is what WW stands for. And colleagues, it's not that the patient has a wheeled walker. We know that. We paid for it. I know who has a wheeled walker. It's not that the patient has a wheeled walker. That's not the signal. The signal is that the clinician called it out in the clinical note. That is the signal, and it's a very strong signal. So after doing this for a while, we finally came to the conclusion, embarrassed to say, the strongest signal in the clinical note is the length of the note. So long notes, bad juju. So the length of the note is the strongest signal inside that. So we use a lot of different types of data, and we purchase data. So we purchase household data on our members and not our members. We purchase publicly available household data. We use that household data to model. So this has been the exchanges. As we came into the exchanges a couple of years ago, that was a frightening place for a lot of insurers. We didn't have any idea who would be enrolling, what their risk would look like. We had to put a premium bid out without seeing what our competitors were doing. I mean, it was really an unknown landscape. And I do believe that other insurers in this region have really suffered financially from this unknown landscape. And lots of other insurers nationally are now pulling out of this particular landscape. But we're not. And here's what we did. We found a group of people we thought would look like the group of people who would come into the exchange of our current members. We took the household data and we modeled on the household data to find the people who were going to show up in the ED. Controlling place of service is everything. It's unplanned care you want to get rid of in your provider system, not care. You want to get rid of unplanned care. So we're looking for people who are going to show up in the emergency room. That's the unplanned care setting, and we're looking for high spenders. So we're modeling that retrospectively on existing members using the household data. So we use their experience to identify the targets. We use the household data to develop the model to point to the people that we're interested in. Then you take away, you don't need the claims data anymore. All you need is the household data. So when somebody enrolls, we're running them through our household data model so that on day 2 that you're in the health plan, if you need care management, you're in care management. We're not waiting 6 months to see 2 emergency room visits on you before we reach out and try to help you you and your physician do a better job of coordinating your care. We are reaching out proactively. This has been extremely important to us and our success on the exchange. Oh, this is great. This is the topology of chronic illness. So here's what we did. So we map everybody to the latitude and longitude. So in our groomed layer, everybody gets their own record in the groomed layer, including the latitude and longitude of where you live, right? Now we can take and map everybody on a physical map. Yes, on a regular old physical map. And here's what we do. In version 1.0, version 2.0 will be more sophisticated, but just getting it off the dime, version 1.0, we make everybody as tall as your stack of chronic illnesses. There's 31, I think. We didn't make them up. They came from the government or somewhere. So things like rheumatoid arthritis, diabetes, COPD, heart failure, chronic illnesses. So everybody is as tall as their vector of chronic illnesses. So you could be ground level if you didn't have any chronic illnesses, or you could be 31 tall if you had chronic illnesses. And then we put you where you live. So if 5 of you are in one household, we put all 5 of you on top of each other. Not stacked on top of each other, but right next to each other. All right, then once we've got that, then we adjust it for population density. Because some of these areas, like this is Uniontown down here. These are there's nothing but deer up here. This is Uniontown down here. So if we didn't adjust it for the population density, all of the topology would look like it was in Allegheny County, just because Allegheny County is so heavily populated. So we adjust it for the population density. We do a little smoothing. You need to use a kernel estimator here, just to do a little smoothing over the top. And now what do I have? I've got a cube. You can take a coronal slice through that cube, however far down you want to go, to find your chronic disease hotspots, as we call them. Otherwise, the topology of chronic disease. And what you see is, so there are 12 sectors. We didn't make those up. We let the data determine where the sectors would be, how many sectors there would be, and where they would be delineated. Right here, holy schmoly, Star City Junction. Does anybody know where that is? Oh my God, don't go there. If you don't know where it is, don't bother. If you know where it is, don't go there. Star City Junction is like the epicenter of disease. So all down here, that piece, diabetes. Diabetes, diabetes, diabetes. Twice the treatment prevalence of diabetes down here as any place else. Where's my, right here, see this little hot spot? Cancer. Twice the treatment prevalence of cancer any place else. So what's in the hot spots varies. That's not that far away, folks. It actually varies pretty dramatically over a small area. Let me show you. You can turn this, so it's a cube. You're taking a slice through it. Now you can look under the slice and see what the landscape of the bottom of these basically icebergs look like. So tall, skinny icebergs like this is a concentrated area of relatively thick people because they're all tall and the base is small. Fatter bases is a more distributed piece of disease here. All right, how are we going to use this? What are we going to do and how are we going to use this? Oh, let me go back here. Let's get our brain around this. Sector 5, as I like to call it, right here, Sector 5. Wow. Here's Sector 5, right here. So all these hospitals that are shown in purple, that would be UPMC, right. All these hospitals that are shown in purple are shown with their catchment area. What's the first thing that stands out? Dang. We don't have a hospital or even a catchment area inside Sector 5. Contracting problem. There are hospitals, and they have catchment inside this sector. They're just not UPMC facilities. We need to do a little partnering here. These are UPMC employed physicians, primary care physicians. We have 6 of them. 6 of them total in this entire Sector 5. It's not that there aren't physicians there, they're just not UPMC employed physicians. There are lots of physicians there. In fact, there's a stunning number of physicians up here. These might be veterinarians in the upper rooms. So here's the piece. So that's just a kind of a smorgasbord of what we do. We do lots and lots and lots of things. We do lots of other things. I could talk for hours about the models that we use and the different applications of them. But here's the danger of big data for us. It's like we're raining dots of information down on people. We discover something and we discover something and we discover something and we throw dots of information at you. And then you ask a question, don't you worry, I'm going to throw more dots of information at you because we haven't woven it into a narrative. So when we keep throwing dots of information at people, this is what they do. If we don't influence the organization, we are wasting our time and the organization is wasting its money. If the way that we handle and message big data results in this, we have put no value on the table whatsoever to our organization. So Herb Simon's probably well known to many people. In Pittsburgh, he spent most of his professional career at CMU. He's a Nobel laureate economist. This was one of my favorite quotes. And he said this in 1971. An information-rich environment creates a scarcity of what it consumes. An information-rich environment creates a scarcity of what it consumes. What does information consume? Your attention, your time and attention. So our job in big data isn't just to spit out more dots of information. Our job is to contextualize knowledge, learn from big data, contextualize the knowledge into the narrative of the organization that allows the organization to be influenced and make different decisions based on big data. Thank you. Yeah.
Hello? Okay, sorry. That was obviously a great presentation. Does anybody have any questions out there?
Yes, sir.
Yeah, Pamela, great talk.
Thank you.
One question. On the patient plot, where you really called out the figure 8 shapes, what influences the shape of these ghost trails between
How strong, so he's asking what influences the path of the ghost trail.
Why do they have that curve in
So, because there's something in the middle of it. So if there were nothing, if the patient were moving directly from Children's to Presby or McGee or whatever, it would just be a smooth, flat piece. If they're making a stop along the way, it distorts the piece. And in this case, the strongest distortion comes from the EMS, the local ambulance service. Questions in the back? Then we'll come here.
I'm curious about how, I'm sorry,
Wow, that was fast. Whoa.
quick with the microphone. I'm curious about how big data analysis interplays with corporate strategy, development, and execution, if you can comment on that a little bit.
Sure. So we have one of the things that, Jennifer? Next. Okay. So one of the things that we do is, which is probably, is very, very different than any other, certainly any other insurer that I know of, so is that the analytics piece of this is right in the middle of the corporate suite. That's extraordinarily unusual. Kaiser Permanente, which is the largest payer-provider system in the country. UPMC is the second largest. All right, it's a distant second, but still, we're still second. Kaiser has a great data scientist shop tucked away in the basement. They don't talk to the corporate people. They aren't in the corporate budget meetings. They are off doing their, over here, ooh, that's science over there. At UPMC, the Insurance Services Division, which I credit Diane Holder with, I'm right in the middle of the corporate suite with the budget planning and the corporate strategy and what we're doing. My job is to look up, see, train, and get off track. I do two things every day when I go to work. I have two objectives. One, be the perfect servant. Know what the organization is going to need before the organization knows they need it, and have it ready. That is my job from an analytics and knowledge perspective. See it, see what's coming, have it ready. The second one is to solve more problems than I cause. So we do it right at the corporate level. We consume it.
Those both sound like tough objectives.
Yes, sir.
Thanks. I think you approach this mostly from the health plan perspective. Mm-hmm. Has the organization been able to take the data and quantify the improvement in preventive care?
Yeah, so this is a good point. Thank you for bringing it up, that this presentation about these data are from the health plan perspective. The health plan and the provider system are quite different in the way they're regulated, how data is created and moved around. Because we are an insurance plan, we're much more pressured from the beginning to have our data organized in a way that could make it consumable. The provider side is standing up behind that with the same kind of discipline at this point. And so, yes, we run it through the preventive cycle and piece of it, both on the provider side and on the insurance side.
Hello, back here. So the presentation's just brilliant, and it demonstrates the curiosity not only of you but the rest of your team to be involved with the business. So it just drives my curiosity. So you could prove to the business that a 2-week period for follow-up phone calls was insufficient, and five days became the norm. So how much do you follow up on the work that you do for the business? And here's an example. What was the preponderance of moving actual, surgical cases from Monday and Tuesday to Wednesday, Thursday, and Friday, so that physicians didn't work on the weekend and then had to follow up for phone calls on Monday and Tuesday? Was there a big change in the operating tactics of the physicians?
That's interesting. I don't know if there was a change in the operating tactics, but we do monitor what happens to the proportion of the 5-day follow-up, and we monitor that by physician group because it's part of their performance metrics. So one of the pieces, the curiosity here, is UPMC overall, certainly the insurance services, enterprises, and the entire organization is extraordinarily different. I give a lot of talks to health systems, big health systems. The appetite here for both innovation and risk is phenomenal within this organization. We're an insurance company. I say that? Oh my God, I work for an insurance company. We're an insurance company. That's about as conservative as you can get in a business. And yet we invest in this and go whole hog at it. It's just an amazing appetite here for innovation.
Any other questions?
Yeah.
There first.
Okay. Insurance companies are usually nonprofit, or some of them are. So in these days, as you look at the wealth of data that you have, obviously although you may be a nonprofit, there's obviously competition among others for the same insurance services. And you might want my dollars and someone else, or the government's dollars. How do you look at the role of what public data should be, government data, Healthcare Act data, and how could that benefit where you are? So you get access to that data, but still it doesn't screw up the competitive advantage that maybe is a good thing in this. I'm not saying that competitive advantage in insurance is good or bad, but there's certainly a lot of discussion about what the government should do to share data, lead you down a certain path versus what you want to do yourself versus Kaiser or anyone else.
So this has been a long contention in the industry about the nature of privacy around data. So CMS data, Medicare, and the state, which has medical assistance data, and then insurance companies who sell commercial insurance own their own data, and self-insured employers, mostly large, but self-insured employers own their own data. So who has ownership over the data, and then how do we share that data without violating the rights of the individuals that data is about? So it's very rare for any entity, including Medicare, to consent an individual to share their data. So, I mean, that's, I think, what the level that it has to happen at. There's a woman in Texas, her name is Pamela Peele, no E on the end. It's always fun to, she's a patient privacy advocate. She's very regimented on this. It's always fun to be on a debate with her, because when you say Dr. Peele, we both answer. Everybody answers. But that's a patient privacy issue that has to be solved. It's not about competition. I think it's good for competition. What should we be doing with these data? We are fiduciary guardians for our clients, be it the government or an employer or an individual. Our job, big part of our job as an insurance company, is to be good fiduciary guardians of your premium, that it's used correctly, that there aren't undue profits. We're a not-for-profit, but that it's used correctly. The more we learn, the better we can manage the delivery of health care. One of the big wasteful pieces of this in care management is if you don't know who's going to have the most value out of your care management, you just start spreading care management resources all over the place. They're expensive. That just drives up your admin costs. What you want to do is figure out who's going to get the highest value out of this care management, and then press that care management down onto that population that's actually going to get value out of it. We have to learn that, and we learn it from our data. The other piece is, even when you have national data sets, you're sorry you asked the question, aren't you? Even when you have national data sets, there's a funny little thing about healthcare. Care is local. And when you groom models on national data sets, you don't get very good performance. When you groom your models on your local data sets, you can really step up the performance of the data set. And so having national data is not in and of itself always that much more helpful.
We have time for one more question.
Right there. Do you need a microphone?
I'll just rephrase it if you like.
Okay.
Well, I also enjoyed your presentation.
Thank you.
You started out saying your IT infrastructure is your IT infrastructure, just that was a $1.6 billion investment.
Yeah.
Can you comment on your ROI for spending that much money and the value that you got out of it?
Wow. So that's our stack. So that's our electronic medical record pieces, that's our stack, that's our ability to onboard additional facilities into that, that's centralizing our IT infrastructure. So I'm not an IT person. I don't go to HIMSS. I can't even imagine how you find your way back to your hotel if you go to HIMSS. So I wouldn't want to comment on the IT ROI, but I can certainly comment on the analytics ROI. I forgot to mention, remember I said it doesn't matter unless it's consumed? I don't care what you make. Make the greatest thing in the world. If nobody comes to the table and consumes it, it doesn't have any value in the organization. So we have a little something we call the electronic filing cabinet, because I cannot think of a better name for it, where we ditch all of this knowledge in a searchable repository, and you can just search on keyword like you were searching Google or whatever, and it has role-based security on it. We monitor who takes what. So now I can look at the depth and breadth of the consumption of these reports and distribution on a quarterly basis. So we do that as well.
All right. Well, thank you so very much. Fantastic presentation.